after. It looks like we're going to have a small but intimate crowd today, so that's okay. We'll also be sharing the recording with other folks that registered and also have it accessible on both our YouTube channel as well as our website. So my name is Danny Nelms. I'm the CEO of Work Institute. Thanks so much for taking time to join us today for today's healthcare retention report supplement webcast. Boy, that's a mouthful. And I am so pleased today to be joined by Raelynn Douglas with Raelynn Consulting. And Raelynn, we've talked about doing this for a long time. We finally made it happen, didn't we?
Yes, everything aligned, and yeah, so happy to be here with you today, Danny.
Thanks so much. Raelynn, if you don't mind, just tell the folks a little bit about yourself, because I think you've got such a perfect background to be talking about retention and retention specifically in healthcare, because you've been both looking at it from the outside and the inside. So if you wouldn't mind just sharing a little bit about yourself and your background, I think that'd be great.
Sure. Well, people will probably tell from our accents that you're south of the border and I'm north of the border. I'm joining you from Regina, Saskatchewan, which is Saskatchewan's my home province. That's where I grew up. Worked for the Ministry of Finance for the majority of my career, and then moved to Ontario, where I jumped into the healthcare system and really got to understand home and community care. Nurses and personal support workers going into the home, which I think is the job of the future, honestly. And then a few years ago, moved back to Regina to take a role with the Ministry of Health. And just recently turned back to my consulting company and wrote a book because I really want to try to have an impact at the system level. I've been working with organizations individually and through the ministries. But I think, if everyone starts to focus on retention, that's not only a competitive advantage, it's a huge financial opportunity. And so I think, what the conversation I would like to bring to everyone in healthcare and beyond is that we can't afford not to invest in our people because we're losing millions or billions of dollars with people leaving. And I love the work that Work Institute does. I've been quoting you. And in fact, in my slide deck last week, I've got stats from Work Institute. I see you guys as the leaders in this conversation. And even though we're in different countries, we have slightly different perspectives. I think the data you share can really help to make my argument for, a high return on investment coming through retention.
Yeah, that's awesome. So for those of you joining us, I just wanted to point out, so every year we put out a national retention report. So this is our 2026 version, came out in late February, early March. And then a few years, not every year, but a few years, we actually choose to call out a particular industry. And we have a lot of experience in the healthcare space. Healthcare is one of the industries, I think, to some degree, does understand there is a cost of turnover, although they don't always act on that as well as I think they could. But we actually create that as a healthcare supplement. We published that just a few weeks ago. And so that's what we're going to focus on today. But if you have not downloaded our retention report, the primary retention report, I encourage you to do that. It's much more in-depth, but the healthcare supplement is meant to just do that, just supplement that report with some deeper dives into some of the healthcare data. And we're certainly going to be talking about some of that today. I encourage you to ask questions along the way, so you can use the Q&A button to ask questions, and we're more than happy to engage in some conversation, especially since we've got kind of a intimate group here today. So feel free to throw out any questions you might have. So where we want to start is, kind of the question that healthcare leaders should be asking. And Raelynn and I are going to point this out along the way. Raelynn is obviously based in Canada, a little bit different dynamics in terms of retention, in terms of the cost of turnover, some of those things, who they impact, how that impacts them. But we're going to try and do both because, again, I just think she's such an expert in understanding this issue that I wanted to bring her in. And so we were talking about this the other day. Turnover in general has improved. If you've been following it here in the US, we've seen some downturn in turnover overall. It has been somewhat of a downturn in healthcare, but yet it doesn't feel that way. For most of our healthcare clients and the folks that we talk to, they still feel very stretched. They feel like they still have dozens, if not hundreds, of open jobs. And from our perspective, it's really this idea of stability is not strength, that there is still controllable turnover that's going down, that there are some underlying issues that are still impacting employees and causing stress and burnout and issues that are underneath the surface that are not necessarily resulting in turnover today, but are very likely to turn into turnover once we get a little bit more certainty around some of the economic things that are happening, especially in the US, but obviously right now affecting the entire world. Raelynn, we talked about it. I think you kind of feel some of the same things there in Canada. Is that right?
Yeah, and I think the only thing I might say I don't quite feel yet is that turnover has improved. I think, our data, I would love to look a little deeper and say, is that incorporating non-permanent full-time equivalents or, people who are working casual roles? Because I think in healthcare, and even in the ministry, the majority of people on my team were part-time. And so they weren't reflected into the data. And there was high turnover in those roles. So, good to see that turnover, from 50,000 feet is improving. But I think, we still have very high rates of burnout. We've got agency nurses to the point where some governments are thinking about legislating against, having those agency nurses working in our provinces. We've got, high absenteeism, lots of people who are going back to school or leaving after working in healthcare for a short period of time, early tenure nurses. And so I think there is still such a high state of turnover. But if I were to look at the data and say, yeah, turnover's improved, I wonder about the people who are remaining. The Canadian Institute of Health Informatics has talked about 93% of nurses experiencing burnout, high 80% in pharmacy. And so, I think there's still a lot of problems in our healthcare system that might not actually be showing in the data yet.
Yeah. No, we definitely agree on that. And one of the things that is somewhat positive here in the US, uh, to at least for economic reasons, but again, this is part of what's putting pressure on so many of these healthcare organizations, is that um, in terms of job creation here in the US, that healthcare industry is pretty much the industry that has buoyed our economy in terms of new jobs. So we still have about 1.5 million open jobs just in the healthcare and social assistance sector, which again reflects a lot of those job openings that are out there. The problem right now is with some of the economic uncertainty, people are just not ready to jump to that other company or jump to that other job. They're kind of hunkered down, but hunkered down does not mean they're engaged. It doesn't mean that they're not at risk of turnover. It doesn't mean that they aren't stressed. It doesn't mean they're not burned out. So those factors are there, and yet we just aren't seeing the turnover as the result, at least here in the US. And obviously you stated it's a little different in Canada. One of the things I think that's unique, Raelynn, and I don't think we've talked about this, is that you mentioned sort of they don't measure some of the non-full-time staff, right? That doesn't factor into the turnover numbers. I think what we get here in the US is that many nurses, many healthcare workers move from full-time to PRN. So they
Mhm.
become some of that, part of their temporary staff, so to speak, that can pick up a shift here or there. But many times they never pick up those shifts. So they don't show up in the turnover because they've simply changed status from full-time to PRN. And so I think in some cases, I think our numbers actually get misrepresented or underrepresented from a
Yeah,
turnover perspective.
people say you design the system that creates the result. And I think, for many years, nurses have chosen to work part-time because of family needs or flexibility in their schedule. And so, just speaking with a gentleman last week who said he's a nurse in Saskatchewan, but he travels to northern Manitoba to work 2 weeks
Wow.
on, 2 weeks off, and it's economically rewarding for him to do that, even though he has to travel great distance. And so I think we have a lot of people that are choosing that style of work, and that might not be reflected in your turnover data.
Yeah. So one of the things that we talk about in our supplement is just the fact that healthcare has, really less margin for error. And maybe that's a bold statement because every industry, there's a lot of really important industries in the US and they serve many constituencies. But, healthcare is such a huge part of our um, social makeup and social fabric, right? And we also have a lot of guardrails, including policies and rules around healthcare, whether it be uh, nurse-patient ratios, things of that nature, that we have to have people in place. And so healthcare is under enormous pressure to fill those positions, to keep their employees, to have them showing up from work, because you mentioned the absenteeism earlier, because there's just not a whole lot of margin for error. And once you do have those job openings, once you do have people that quit, it almost has a downstream effect because it affects everybody else on that floor or on that shift or in that particular department, or in the organization as a whole. um, I think you would agree with this, Raelynn, that there's just so little room for error.
Little room for error and high cost of risk associated
Right.
with it. When you think, how expensive it is to train a nurse or doctor, the years of education, the on-the-job training, the onboarding. And so when we think about replacing a nurse, we'll just use that as an example. We say it's about $75,000 per. $15,000 is the estimate that Work Institute uses for an average employee. Um, those things are, sort of the direct and indirect, but all of the hidden costs that we don't even mention, the reputational risk, the patient safety risk, the inability to hire because of that environment. Those are long-standing costs that continue to fester away on our budgets that is hidden between all those different line items. And so no one is calculating that total cost. And we're not talking about it as a major drain on our economics as well as our social fabric.
Yeah. So we're not going to dig into a lot of this today, but on this particular slide, if you see here, one of the things that we do point out in our supplement is where there are differences between healthcare and non-healthcare organizations in terms of why people leave. And I think that, we see this as something that's extremely important, is that we need to understand why people are leaving. And I think people misunderstand exit interviews a lot of times. I think they think of them as kind of a post-mortem, or why do I care about why this person's leaving? And it really matters because it's all a predictive analytic. It's predicting why people are going to leave in the future. So we have to understand these things. Some of the things that we see is that career reasons are a little bit higher in non-healthcare organizations. But we see work-life balance is massive in terms of, it's getting close to at least a third greater in healthcare organizations than it is in other type of industries. We see relocation as higher. The management one really concerns me because we just, it's such a critical industry both in Canada and in the US, and yet we have managers that are not being effective. And so, most of the others are fairly consistent. We've got a health and family is a little bit higher in non-healthcare. But one of the things that we always talk about, Raelynn, and I know you agree, is that for the most part, other than involuntary, maybe to some degree retirement, maybe to some degree relocation, these other things are controllable. Companies can prevent, not maybe not all of it, but they are preventable things. They're things that if they understand them and they act on them appropriately, we can actually improve. And that's one of the reasons I wanted you on today, is because you've been in the trenches trying to help companies to actually take action and make improvements around retention. I just don't think enough is, I think, see if you agree with me here. I just think too many times turnover is just accepted as a cost of doing business, that it is what it is.
Mhm.
And yet you don't see it as sort of this burning platform. And I've argued for years that even if your turnover is only 15, 20%, if we were losing 15 to 20% of our customers, or 15 or 20% of our patients said they'll never step foot in our organ, be a patient in our organization, there would be, I mean, unlimited amount of time and energy being spent to try and solve that.
Absolutely. And I don't know what it is about healthcare organizations and the disconnect between, how we budget at home and how we budget at work. It's just like, oh, well, we're $1 million over. Oh my God, right? And I think the healthcare crisis is a crisis and it's become commonplace, right? It's no longer the burning platform, as you mentioned, it's not making news. And so I love working together with you, Danny, on this problem because you're talking about big numbers, you're talking about billions, you're talking about fiduciary breach. You're using language that I might not be as comfortable using, but you're right. And so I think, when people say, oh, you have a 30% turnover rate, that looks okay on paper. It could be worse. Or our turnover rate isn't so bad, right? There's these words that sort of just dismiss it. But if you were held responsible for retention of your staff and the savings that would result, it would be a very different conversation. And so I think it is important, and thank you so much for doing a healthcare supplement on this work, because it is interesting to see the difference between, and if health and family is lower in healthcare, I wonder if it's because healthcare leaders know if I'm sick, I'm taking the time off. If my child or my parent is sick, I'm making those amends, whereas people in other careers might not be able to prioritize that. But otherwise, yeah, I agree with you. It's shocking to me a little bit, some of those, management and work-life balance for sure would definitely be one that I'm not surprised to see.
Yeah, and I don't want to dig too deep into this because we could go down the rabbit hole that never ends. I think there's a really interesting dynamic in healthcare in that to some degree there's not enough flexibility, but to some degree there is some flexibility. That a lot of and I know we're going to talk about nurses a lot today, but nurses are such a huge part of the healthcare industry and making it work. But you certainly hear of a lot of nurses who go into the nursing profession and then they get to a certain point and they love it because they can work 4 days a week. They might work 12-hour shifts or longer, but they're able to work 3-4 days. Maybe they're just working on the weekends, and that allows them to take care of children during the week. So there does seem to be some level of flexibility in the system. The problem gets back to when we have turnover, when we have open positions, when we're not fully staffed, some of that flexibility disappears.
Absolutely. Yeah,
So,
I agree with you. Yeah.
so one of the things that we wanted to really point out is that the turnover risk and the turnover reasons actually uh, more probably more so in healthcare than in others is that it actually kind of changes over time, right? So when we look at the first year and even into the 1 to 3 years, what we see is that different issues come to bear more acutely. And I think that this is another one of those things that's important to understand. And for those of you that might not have this kind of data, I know many of you are Work Institute clients, but this is the kind of drill down. This is the way we have to look at this data in order to really start to figure out how are we going to fix it. But one of the things we know for sure is that first year turnover generally is where most of our turnover occurs. It's somewhere in that 35 to 40% of all turnover actually occurs in the first year. And one of the things that we call out here is work-life balance. But really, when you look underneath that, because again, for those of you that have not seen our reports, we categorize everything with a larger category, and then underneath that we have sub themes. So in this work-life balance category, there's actually several. I don't remember, I think it's 4 or 5 off the top of my head, but one of those is scheduling, or it's the schedule piece. And by far in healthcare, the schedule is what dictates a good portion of this work-life balance. We have other things like commute, some of those kind of things that can be factors, but the scheduling aspect is huge. And what always surprises me in healthcare is that that's the thing that shows up so acutely in that first 90 days. It's like we're not telling people what their schedule is going to be. And Raelynn, I was wondering what is it about this hiring process and in that first 90 days? Why do you think people are so at risk of leaving and just leave so quickly? Do we just not do we not hire the right people, or are we not giving them a true realistic job review and telling them all the little things that are going to happen early on?
There's probably a million answers to that question, a million reasons. But based on my own experience, we were hiring people for a role in our organization. It was kind of like a call center, right? But this young woman who approached me, I wrote about her in my books, had the Sunday scaries because she hated talking to clients on the phone and being yelled at. It's like, how come we didn't tell you in the interview and the onboarding process that this is part of your job? Okay, we need to step back and make sure we're clearly communicating what are the expectations, make sure people are fully trained and capable of doing this, because their first 90 days, they're comparing us to their previous job, or they're still looking, they're still evaluating. So that's a crucial time to make sure we're clearly communicating, we're setting expectations, we're giving the resources that people need. And I think, it's having that engagement with people to say, how is this going? Can we supplement some of this difficult stuff with some fun? How can we make work joyful? How can we, make you feel like you're part of a team? Because people will do very, very difficult work if they feel that they're not alone, that people see them, they appreciate them, and that they're continually trained and supported. Clint Studer wrote a book about, the 30, 60, 90-day check-ins. And Gallup has done a lot of work on this too, right? And people would stay if somebody just checked in on them and asked how they're doing. And so I think the reason behind all this is scarcity of time, right?
Yeah.
We don't have time as leaders to properly evaluate our onboarding process. We're just filling the seats and running on to, put out the next fire. So.
Well, and Raelynn, we asked the question that we hear from employees is a version of, can I do this work? And I want to step away from, we talk so much about nurses, and we'll talk more about them as we go along, but there's a whole other sector of workers in healthcare, right? And even if we're talking about CNAs and folks that might have a nursing title, but they're not a registered nurse, or they're not a clinical nurse per se. But there's so many support folks in healthcare, and yet healthcare is a highly stressful environment. There are real consequences to mistakes. And so I think a lot of times when people get into healthcare that are not clinically trained in healthcare, they're asking themselves, can I do this? And yet, to your point about the onboarding, there's often not much of a support system there for them to lean on. And I think they literally just self-select out because they're not sure they're able to do that work. Is that accurate?
I think so. And, in home and community care in Ontario, I looked a lot at personal support workers, which are, they're not nurses. I'm not sure what term you would use in the States, but home care aides or, continuing care aides who go in and do activities of daily living, right? Bathing, showering, helping people out of bed, and not very well paid. Most people are coming in as, new Canadians, challenged with the language, with housing, with transportation, all these things. And we're competing for those people for the same minimum wages as hospitality and restaurants and that kind of thing, right? So when I think about retention solutions, we need to think about table stakes. Are people hired appropriately for the role? Are they getting the competitive wage? Do they have full-time hours so they can pay their rent? Those are kind of the hygiene conditions of work. And then are they working in a supportive environment where they continue to grow and learn, where they have mentorship or support? These are the basic things that nurses would say that they used to do when they had time, but now they're all running short and they're scrambling. So I need to think we need to get back to the basics to say, what do people need to just fully thrive? They're trained, educated, how do we help them do the basics that they, not just basics, but you know what I mean, the foundational work, help people stay.
Well, and then I want to get back to the nurses for a minute, because what we start to see then within that 90 days to a year is that already most healthcare workers are already looking to the future. They're already trying to see, can I grow here? Can I advance here? How am I going to grow? How am I going to advance? And they quickly start to ask those questions. I mean, there's a lot of similarities with other industries, but for sure in healthcare, and especially for nurses, they start to ask those questions early on because that is their career. That's what they've chosen, their chosen field. And if they go into an organization that isn't showing them where they can go, how they're going to get there, how this organization is going to help them to achieve their career objectives, they'll leave. They'll
Absolutely.
leave that quickly.
Yeah, and so you and I have talked a lot about stay interviews. Exit interviews give you the data, but stay interviews allow you to have those conversations because there may be a very ambitious nurse who's just graduated, but she's thinking about becoming a nurse practitioner. What is the path for her? Last week we had a nurse retention forum, and a lot of the language was around mentorship, right? They want to know, they want to have pride in their profession. They want to know what the next steps are. And there were so many nurses in that room that had PhDs, masters, working on research projects. It was remarkable to see the amazing career path that these nurses have access to them, but we don't necessarily know about it because we're so busy, trying to get through the day. So how do we share that information? And I think one of the advantages that we're in now is that we've got access to micro-credentialing, right? You don't need to take 2 years off your role to go and become, the next level, master's level nurse. You could take a wound care micro credential, right? And you can do it remotely. So I think there is opportunity for nurses, other healthcare professionals to define their own career path and advocate for themselves to say, I'm very interested in pediatrics or stroke or whatever the case may be. Help me get there. But don't see that as a threat that this person is leaving. They're working within the healthcare system. And if you're a supportive leader that says, yes, I want to help you get additional credentials, that will come back through loyalty and I don't know, I don't want to say good karma, but reputation and brand where people say, I liked working for that organization because they really supported me in growing. And they might come back to you, you know.
Yeah.
Workplace is small.
I wholeheartedly agree. I mean, you can't train, it's the old adage, I can't remember, I think it was runs, it's one of the hospitality leaders said, if we train them, they'll leave. And if we don't train them, they'll leave, I
Yeah.
mean, it's one way or the other. So we've got to be on that real quickly. And then I want to keep moving on is that we have to understand too, in that 1 to 3 year period that we start to get some risk. I mean, we've looked pretty deep into the data around relocation, and we don't find too often that people are running away from something. However, in healthcare professionals generally are very portable. They can
Mhm.
go wherever. I mean, you could leave Tennessee where we're located and you could go to Texas tomorrow and you could have a job in a few days. No
Yeah.
doubt about it. If you've got the right credentials. So they become very portable. They can move around geographically. So you have to recognize those risks that exist, and also, you have to become the best employer you can possibly be because that's what's going to help you retain those folks. They're going to say, well, yeah, I could get a job somewhere else, but it wouldn't be as good as here. And so that's the decision you want them to be able to make and that they're talking about from a standpoint. So I want to switch topics a little bit, Raelynn, because we talk about retention and in a sense, we're still talking about it here. But I think it's like I said at the outset, we've got lower turnover, at least here in the US, but I don't think we have higher engagement. I think we're seeing, and I'm going to show some stats here in a couple of minutes, but there is burnout. There is a reduced discretionary effort. We've got leadership fatigue. We've got the lower patient experience, at least in some organizations. We've got lower organizational performance. All of these are happening while turnover is down. So we can't just look at retention as being the only goal. We can continue to improve retention. But if we have other issues, and we talk about them as the conditions, right? We need to be looking at the underlying conditions. What conditions are creating performance? What conditions are creating productivity? Conditions are creating engagement? What are conditions are creating retention? If we're not constantly evaluating those and assessing those underlying conditions, all of those things can come back to bite us. And I think for a lot of companies, they're surveying the wrong things, they're asking the wrong questions, they're relying on some engagement score that doesn't really mean anything. And this I know you talk a ton about in your book, and we're going to talk a lot more about your book before we get out of here. But this is a lot of what you're talking about, is all of these underlying conditions that exist in healthcare.
Hmm. Well, and it's interesting. I like to think of flipping it on its head, right? Because when I first approached this work, I would go to people and I'd say, "What's your turnover rate?" And they say, "I don't know. We don't have good data," or "It's fine," right? So then the question isn't what is your turnover rate? Is like, that's an outcome, right? If you have high turnover, you've got a problem. So let's design it upstream and say, what are all the things we're doing to prevent burnout, to increase engagement, to have conversations about career development, to get people excited about work again. Because if all of those things happen, you're going to see improvements in that metric. And so I think we need to change the conversation, that it's not just, a turnover metric that we're focusing on. We're going to design upstream, and your example of making sure people know what their job is, right? Having a compassionate leader, having friends at work, people you can have fun with. I talked to a CEO of a hospital a few years ago about, what are you doing to retain your staff? And it was a rural community. And she said, well, we're attracting people here for the work. We're a good employer. People recognize that. But if they go back to school, they leave our community, go back to school, they fall in love, they leave, right? Like, we're losing them because of the stage of life they're in. Maybe we need to have more dances, right? Maybe we need people to fall in love in their home community and buy a house, have children, because then people put down roots. And so, I mean, it's a funny, example, but it's true. And I think Saskatchewan and maybe, Tennessee, you've got, different population. You can draw people there. They can have a great life. They could, they don't have to move far away. And so what are some of these other community conditions that we can say are really leading to a high quality of life? Maybe it's even beyond the workplace, right? A lower commute, being able to walk to work, having great housing. I was just in Alberta a few weeks ago when they have a rural economic health policy where they've got volunteer municipal committees that are talking about attraction, integration, and retention. So they're focusing on the health workforce as a primary driver of their economy in those rural communities, and saying we need to attract and retain these healthcare professionals so that our communities can thrive. So that's a very different take on the problem, right?
Hey, Raelynn, I want to go back. I'm sorry, Keith, I missed your question. I got to pay attention to that little red dot that comes up. But Keith asked a question about if we would expand on the workforce scheduling practice that we mentioned in the work-life balance piece, especially the shift schedule piece of the report. We may have answered your question, Keith. I'm not sure. But again, I want to go back to the idea that shift schedule is that primary driver. And again, there's an element of flexibility that exists within healthcare, but I also think for certain organizations, there's still too much rigidity. We still have this idea that this is our scheduling practices. This is the way we're going to do it. We're always going to do, 8-hour shifts, or we're always going to do 10-hour shifts, and people always have to show up and do rounds at a certain time. I just think we're going to get to the point where we're going to have to build more flexibility into the system as a whole, that we're not going to be able to just say, here's our practice, this is what we do, you either take it or you leave it. I just simply think the constraints are going to become that we're going to have to be much more creative. Would you agree with that, Raelynn?
Yeah, and I think there's so many examples we can draw on from other sectors. My daughter was working in a restaurant, and that team of servers would communicate with one another and text and say, oh, something comes up, can you carry my shift or cover my shift? So yes, it's not life and death, it's a restaurant, but there's a human element to that, teamwork, covering for each other, that perhaps we could explore in some of our healthcare organizations. And I know we've got collective agreements and we've got unions and, a lot of constraints against that. But I was part of a healthcare workforce innovation challenge with Healthcare Excellence Canada a few years ago. And some of those smaller teams were able to amend the schedules and to be a little bit more innovative and flexible, because it comes down to communication, essentially, and having a tool that allows you to communicate and not have it up to one, manager who has to see the whole thing. Trust and autonomy is part of it as well.
Well, I think there's two things. I'm pretty sure it's out there. I could be wrong, but I know that there have been some pretty big technical advances in terms of there are apps that some of the larger healthcare systems have that allow for that shift sharing or switching kind of thing. So it's all right there. So you just go onto the app and you say that I've got this shift available, or I need someone to take this shift, and they're able to do that through technology. I think what I'm getting at to some degree, though, is the rigidity we have in just the schedule itself, meaning it's always got to be from 8 a.m. to 8 p.m., right? And at some point, we're going to have to recognize that, well, we're going to have to create some 6 a.m. shifts, and we're going to have to create some 10 a.m. shifts, and we're going to have to do some of those things because we're just going to need to create more flexibility in the system at its core, not just the flexibility piece, not just the covering shifts when people need to change because of those things, but I think we're going to have to get better at that. We're seeing that in manufacturing, interestingly enough, and I think manufacturing has been more hardcore even than healthcare, right? It was, we're doing 4-day, 10-hour shifts, and they always start at, 6 a.m. and they end at, 4 p.m. And that's the way it is. And that's the way it's always going to be. And we're starting to see shifts in that mentality and saying, we can't just do it that way, because if we're going to attract enough workers, we're going to have to be able to figure out where we've got working families that have to drop kids off at school. And so they can't work a job unless the shift allows for them to not start until, say, 7:30 or 8 o'clock. That's just going to have to be part of what we build into it. I want to keep moving because I don't want to go over time, but I mentioned I was going to provide some data. These are our core drivers. We've been measuring core drivers for years now here at Work Institute, and we've got a lot of evidence and a lot of research proving that these core drivers are highly predictive of intent to leave, including reasons why people are leaving. And so when you look at these, what we see is that for the most part, they're pretty flat. Now, we use something called a net excellence score, which is where we take the excellent ratings and subtract the fair poor ratings. We like to see these scores in the 35 range or better, and we see the team score actually meets that expectation. All the other three are below. Now, this is pretty consistent across industries that we see. But if had this chart gone all the way back to 2019, we would have actually seen a little bit of a bump, which is even surprising in healthcare that we got that bump. But since then, there's been no improvement in terms of how people are perceiving these core drivers. And that's, again, why we're saying that the lower turnover actually isn't increasing my perceptions around these four core drivers. That's where the trouble is. That's where we see a real problem. So the other thing I wanted to mention, and we talked a little bit about this, is, are we measuring the right things? And we talked about turnover as an outcome, engagement as an outcome, retention as an outcome. And we talked about this idea of workplace conditions. One of the things that I wanted to bring up here is this idea of how we look at measurements themselves. And Raelynn, we didn't talk about this the other day. It just kind of occurred to me when I was looking through this morning. But I've been on this soapbox for years, but my number one issue in the survey industry is this idea of looking at favorable ratings. If it's a 5-point Likert scale, strongly agree to strongly disagree, we tend to group those those top scores and add the strongly agrees to agrees together to form a favorable score. The problem is that becomes the measurement that we're looking at, and it tends to be overinflated, and it has no predictive value to things like intent to leave. So we're looking at a score that doesn't provide us any real outcomes. We have to be looking at that excellent score. That's what's highly correlated to risk. And yet, so I think we're measuring, and in this case, let's not say we're measuring the wrong thing, we're analyzing the data wrong. And it's giving us a false sense of the fact that we're okay because 86% of our employees are giving us favorable ratings, when only 50% are giving us excellent ratings. So we've got a big portion of our workforce that's at risk that we're not even recognizing. Do you see the same thing in Canada in terms of the scoring mechanism?
I think you're right. Like that's a astute observation. And when I look at surveys, it's like, oh, we're doing okay. We had 30% participate, or we had, the majority of people are feeling fine. The real story behind it is that people aren't doing fine. And if they're not participating in your engagement survey, there's a problem, right? And I talk about that in my book, that there are issues here. And it's tough to go to a town hall meeting or to a all staff meeting and saying, you guys are complaining and we hear you, right? Like we've got some work to do. But that's the honest conversation. And most leaders aren't really willing to have that. Let's gloss over, let's put the survey away and let's issue it again 2 years from now. Yeah, I could talk about this for hours.
Well, you mentioned the book, so I think it's a great segue. Raelynn has written a new book that just out in the last couple of weeks called The $1 Billion Blind Spot. I did the math, Raelynn. Our problem here in the US is $100 billion problem.
Mhm.
Turnover in the US healthcare segment is costing $100 billion, 107 billion to be exact. So it is $100 billion problem. But just quickly tell us a little bit about your book and why you think people should want to read it.
Yeah, so thank you, Danny, for allowing me the opportunity to talk about it. Years ago when I was working in Ontario in home and community care, I was working with organizations who had high turnover rate. That wasn't the conversation we were having. We were talking about, patient outcomes and missed visits and, not being high performers as far as service providers are going. And when I asked to look at the data, first of all, they didn't have it, right? And so we had to dig for it. But when I found an organization that was willing to share their data, there were red flags all over the place. People leaving, 40% turnover in nurse managers. People leaving after the first shift. And I said, "Have you calculated the cost of this?" "Oh, no." "Has anyone ever asked you what your turnover rate is?" "No. We're too busy, backfilling shifts and doing the work of healthcare to think about this as a policy issue or as a shift." So when I did my MBA, I added up those numbers and I said, it's shocking to me how we're not asking the question. It's invisible and no one owns the responsibility because, finance is worried about cost overruns and overtime and HR is worried about the, resiliency program or the well-being lunch. And they're looking at different sets of data. And every time we have a downturn, we let people go, we freeze hiring, we cancel leadership development, and then we have an upturn and we're hiring again. So I started to think, how do we get this message across? Because, I was in an organization not too long ago, 400 staff, and there was 100 new people hired. What is the cost of that? Are we, where's that money coming from, right? And so when you think if you calculate a $107 billion problem in the US, where's that coming from? It's coming from taxpayers, it's coming from people paying their bills. And in Canada, we have a different healthcare system, obviously. It's provincially funded. The majority of our provincial budgets are healthcare. The majority of that is labor. And so you think almost 50% of every dollar is being spent on this problem. It's worth paying attention to. And so how do we turn it around and to be a conversation about leadership, about kindness, about making eye contact, saying thank you, improving conditions of work so people have fun, they love being there. And when you ask nurses, and they're not asking for more money, as long as it's competitive, they're doing okay, but they want mentorship, opportunities for growth. They want to, have a safe place to raise their family with a compassionate boss who understands that they have to go home for the, fridge repair guy, right? And so I think, the solutions are so easy, but yet, we're not talking about them yet.
Well, and you mentioned it earlier, Raelynn, and this is certainly our perspective here at the Work Institute is that when we have uncontrolled turnover, when we're not doing everything we can, it's literally a fiduciary breach. Like it is a fiduciary responsibility that companies should be looking out after every dollar. And if we have 22% turnover that's costing us $18 million a year, that's a fiduciary responsibility. That's a fiduciary issue. And yet we're not looking at it that way either. So it's either not being looked at all, and it's certainly not being looked at through that fiduciary lens.
And
So,
I just to add to that, Danny, and thank you for adding that stronger language. I think no one is responsible for it, so no one's accountable for it. And when you say, like we need to be paying attention, if retention is your number one priority, everything you do is different. And if you hold those leaders accountable for those behaviors, you will see change.
So in our supplement, we talk about 5 imperatives for healthcare leaders, and this is really coming straight from the data. We talk about having to address work-life balance structurally, making sure we've got all the infrastructure, right policies, right procedures, the right things there. you have to win the first 90 days. It's absolutely critical that we win those first 90 days. We've got to anticipate this idea of workforce mobility and the fact that people can relocate. We've got to stop mistaking endurance or the fact that people are just staying for engagement. They're two different things. They have two different outcomes. And we definitely have to create sustainable career growth. Raelynn, you also talk about a couple of other things in your book that I wanted to give you a chance to mention, if you'd like, in terms of just some of the things that are absolute imperatives right now that we do in the workplace if we're going to retain our healthcare workers.
Mm-hmm. Thank you, Danny. Like the first part of the book, I talk about the cost and why it's hidden. The second 2/3 of the book are toolkits for leaders, to improve communications, to have more leadership presence, to take care of ourselves, with resilience practices. And leaders are human too, right? So there's some fundamentals that I think healthcare leaders need to think about. How we talk to our staff, how we convey common values. And then as the book progresses, I move into a little bit more complicated leadership ideas like performance measurement, evaluation, and then communicating the ROI. Because most healthcare leaders are uncomfortable talking about return on investment. HR in particular, that's not language they use. So how do we help leaders evaluate whether a leadership development program is a good use of money, right? And how do we communicate back to our senior leaders that this is exactly the investment we need? Because if we retain our healthcare workers, we're not going to be losing the millions of dollars that are leaking. And it's a skill set, right? And so my book is filled with tools. Some will be relevant to some will be too rudimentary or too advanced. But my hope is that it changes the conversation, that leaders can pick up the book and start having those conversations.
And for those that would like to pick up your book, we've got a QR code here if anybody would like that. Raelynn also has, I think it's raesoleilconsulting.com. Is that right? The website?
Raesoleil.com. Yeah.
Okay, raesoleil.com. You can also find it on Amazon, so definitely go check out The $1 Billion Blind Spot. I was very honored that Raelynn actually asked me to write the foreword for the book, so you'll get a little taste of me in there as well. So Raelynn, thanks so much for doing this today. We need to wrap up. I want to just remind folks to go, if you have not seen our retention report, I encourage you to download it. It's chock full of 50 pages worth of information. If you've not downloaded the healthcare supplement, it's available. If you can't find it, reach out to us at workinstitute.com. We certainly can get it to you. But I think one of the things too is just you've got to fully understand why people are leaving, and we've got to be putting more emphasis on what are we going to do to make sure that when this economy turns, when things are starting to heat up a little bit, we create more jobs, that we're not going to be the ones upside down feeling the next great resignation, because I think it's out there. I think it's coming. And I think that we're starting to rest on our laurels a little bit right now in terms of the fact that it's down, but we cannot mistake the lack of turnover for stability, because there is a lot of things underneath the surface that we need to be looking for right now. We can certainly help you out here at Work Institute, whether that's doing engagement assessments, whether that's doing stay interviews. Raelynn's got some things that she does with a lot of Canadian partners, but she also works here in the U.S. So we can connect you to her potentially if there's some very specific things that she might be able to help you with. But right now is the time for action. Right now is the time that we need to be doing something. So Raelynn, thanks again so much for joining us. If anybody has any additional questions, now's a great time to ask them. But other than that, we're going to sign off here in the next minute or so. Any final words, Raelynn?
I think this was a great conversation, Danny. I always enjoy speaking with you, and thank you for being part of my journey. I consider you a friend and a mentor. And also, all of the reports that Work Institute puts out have been great, easy to read, easy to follow, deep knowledge and information. So I've been a big fan of your work for many years, and I appreciate the opportunity to stay connected.
Sounds great. Well, we'll talk soon. Thanks everybody for joining us. For those that are going to see on this recording, I hope you get something out of it. And we'll talk to everybody soon. Thanks so much. Have a great day.
Thank you.